Hi, everyone who's watching this. Welcome to our pre-recorded presentation on supporting your autistic child to navigate their world. I'm going to be talking about understanding and advocating for your child's unique needs. Before we get started, I just wanted to start with an acknowledgement of country. So although we are virtually gathered and distributed across different locations today, Playroom Therapy would like to acknowledge the traditional custodians of all the unceded lands, skies, and waterways, and pay our respects to elders past, present, and emerging. I'm on Wurundjeri country today here in Naarm, so I'm thinking about those traditional custodians as well as all the different traditional custodians of the lands that anyone tuning in might be on. I'm going to do a quick introduction to myself in case anyone watching hasn't met me before. So my name's Meg. I'm a registered play therapist supervisor who works here at Playroom Therapy. I also am a bit of an academic or a researcher. I've done a little bit of research specifically in nature-based play therapy. Had that published a couple times. I've also done some marking and worked at Deakin University previously. Prior to being a play therapist, was a early childhood teacher for about 10 years, working in a number of different settings, both here in Melbourne as well as regional Victoria, teaching mostly 3 and 4-year-old kindergarten. And I guess importantly for this presentation, I also want to share that I am a neurodivergent person. I think we'll talk about it later, but it's really important when you're accessing information about neurodiversity and being neurodivergent to seek information from neurodiverse or neurodivergent people. And although I am myself multiply neurodivergent, I think it's also really important for me to seek information from other neurodivergent people and experts. And so I've tried to do that throughout this presentation. So what this presentation will cover, we're going to talk about some key concepts to start off with, including what is neurodiversity and what does it mean to be neurodivergent. And we're going to briefly touch on the different models of disability, just to really situate this information in this presentation in some really grounded concepts. We're going to talk about autism or autism spectrum disorder and what that actually means. We're going to talk about neurodiverse parenting strategies, as well as some information around neurodiverse affirming practice more broadly if you're looking for support services for your child. We're going to talk about some different strategies and supports that can be helpful for autistic people and autistic children. I'm going to give you some references and places you might like to seek some further information. And we're not going to have any time for questions. I should have edited that out of this slide. It's the pre-recorded version. But if you do have any questions, my contact details will be at the end of the presentation. And you can always reach out either to Playroom Therapy or to me directly if you want to chat through anything that's in this presentation. So before I start my presentation, I just want to quickly touch on the concept of person first versus identity first language. So person first language is designed to put the person before their condition or disability. So you might see this like person with autism or children with autism. And identity first language puts a person's condition or disability at the start of the identity. So for example, this would be an autistic person or an autistic child. Lots of autistic people and autism experts and advocates would prefer identity first language because it indicates that being autistic is an inherent part of someone's identity rather than an addition. So they would be saying, I am autistic, I'm an autistic person. There are people out there that have different opinions about the correct way to talk about autism in terms of someone's identity. And so if I know what someone's preference is personally, I will always defer to using that. So if someone prefer me to say that they're a person with autism or they have a child with autism, that's what I'll use. But in general, throughout this presentation, you'll see that I tend to use identity first language, so autistic children, autistic people, as I believe that this is often the preference. And, I engage with those advocacy and expert bodies that promote this identity first language. So to start off with, we're going to talk about what neurodiversity and neurodivergent means. So the concept of neurodiversity is most easily understood when the term is broken down into parts. So if we think about it, neuro means related to nerves or the nervous system, including the brain, and diversity is this idea that everyone is different or there's a natural variance in any general population. So if you combine that, you get this idea of neurodiversity, that there are lots of different types of brains and nervous systems within our population. The term neurodiversity was coined in a paper presented by an Australian sociologist, which I think is really cool, but it comes from Australia, Dr. Jeannie Singer in 1998. Her work as a neurodiversity pioneer ignited a greater conversation around the idea that societal influence is one of, if not the main obstacle for those who think or perceive or engage in their world differently. So neurodivergent people experience and interact with and interpret their world in unique ways compared to neurotypical people. So you can think of neurodivergent as an umbrella term for anybody who has a mind or a brain that diverges from what's seen as socially or society as typical or normal. So you might see neurotypical used in that way. This can refer to a number of different parts of a person. So it can refer to attention, functioning, mood, processing, learning, behavior. It can be genetic. It can be acquired. So having an acquired brain injury, for example, would fall under that neurodiversity umbrella. It can be neurodevelopmental. People might consider their neurodivergence as an intrinsic part of themselves. So as I mentioned earlier with that identity first language, people consider their autistic traits to be an intrinsic part of themselves. Other people might not consider their neurodiversity or their neurodivergent elements to be an ingrained or intrinsic part of themselves. So we can think of neurodivergent as an umbrella term. You can see in this image here from Colorblind Zebra, lots of the different things that might fall underneath that neurodivergent umbrella, whether it's autism or ADHD or things like OCD or acquired brain injuries I mentioned, dyslexia, dyspraxia, different learning disabilities, DID, dissociative identity disorder, lots of different things fall underneath there. It's important to note that approximately 1 in 5 people will be diagnosed with something that falls under that neurodivergent umbrella in their lifetime. So things like even Alzheimer's can fall underneath there. If we talk about the different models of disability, we can think about the medical model of disability and the social model of disability. So these are often commonly discussed models of disability in the disability space. So the social model of disability says that disability is caused by the way that society or the support team around the child is organized. And the medical model of disability says that people are disabled by their impairments or their differences. So there's a really different space in terms of where the support and the focus is placed on in these two different models. So within a medical model, disability is viewed as a health condition that can be dealt with or supported by medical professionals. People who are disabled with a disability are thought to be different to what is typical. Disability is seen to be a problem of the individual to deal with. So the medical model views autism as well as other neurodivergent conditions like ADHD, for example, as a defect or a disorder. That's why it's called autism spectrum disorder under that medical model. And so with that view of the medical model, often this can come along with this idea that something needs to be fixed or that the person themselves needs to move towards the norm or standard way of being. So if we think about lots of spaces that talk about autism, this might be the focus. And in a minute, we're going to talk about the DSM diagnostic tool for autism. And this is very, very situated in this medical model of disability. The other way we can talk about disability is through the social model. So disability in the social model is the result of the interaction between people who have impairments or have additional support needs and an environment that can be filled with physical, attitudinal, communication, and social barriers. So within this model, the focus is on changing the environment, attitudes, and social barriers around the person so the person themselves is able to thrive without having to change who they are inherently as a person. So it's a very different focus on where the support needs need to be placed and I guess who needs to do the work around supporting somebody with a disability or with one of these diagnoses. The focus is on educating and fixing the environment rather than the individual. And so this model embraces the idea that there's no right or wrong way to be, and that people are just different and that they need different supports to allow them to participate in society and in different places in a way that feels okay and good for them. The social model, importantly, doesn't deny the reality of impairment. It doesn't say that it's not challenging to have impairments or things that you need support with. And it doesn't deny the reality that that can have an impact on the individual. But it does challenge the physical, attitudinal, communication, and social environment and how people around that person or that child are accommodating that child's or that person's impairment. Ultimately, how a person with a disability chooses to view or talk about their impairment or their diagnosis, whether this is within the medical model of disability or within the social model of disability, is up to them. But you will note that throughout this presentation, I do default towards the social model disability, as this is generally considered to be more neurodiverse affirming. But due to the prevalence of the medical model within things like diagnosis, as I mentioned, you'll see me talk about that perspective a little bit too, as I think it's important to think to, as a parent navigating having a child with autism or a child who's been diagnosed, it's important to know a little bit about the medical model, as that can be the predominant model used in some spaces. I want to start off before we talk about the diagnostic process with acknowledging that several different elements can impair the capacity and likelihood of someone to be able to access support and receive a diagnosis. So these can be things like socioeconomic status, gender. We know, particularly with autism, for example, that girls are often take longer to be diagnosed and spend more time misdiagnosed with things. Race can play a big role. Again, when we think about here in Australia, our First Nations people and also overseas, African American children, for example, are much less likely to be correctly diagnosed with autism based on racial stereotypes. Culture can play a role in when we might be able to access a diagnosis and support, as well as age. And so many people experience stigma and feel concern around the impact of receiving a diagnosis. And this can also include parents thinking about their child receiving a diagnosis. Along with this concern and stigma, wait times can be really lengthy. Not everybody is able to advocate within a medical context. You might be very certain that your child deserves to be assessed and receive support, but there might not be capacity or power within places, for example, like NDIS or with a pediatrician. There can be a power imbalance and can be very difficult to advocate for what you feel is right. Some people may themselves have been parented in a way that didn't support receiving a diagnosis. People can be concerned that diagnosis would be weaponized against them. People might be concerned around the loss of rights, including impacting things like immigration, child custody issues, employment. They may be concerned around being received as medication seeking. So if we think about people who've got ADHD, for example, and that medication fits into a stimulant category, people might be thinking about, oh, am I going to be drug tested for work? People also might be thinking about the impact on being able to drive. So there was, I think maybe a year or so ago, some driver's license changes came into Queensland in regards to autistic people having to disclose their autism as part of their driving assessment. People might be worried about that. Even though not all neurodivergent people have access to formal diagnosis, the view that we take at Playroom Therapy and lots of other spaces take as well is that it's important to build practices and settings that support everyone needs, even if there hasn't been a formal diagnosis. And this, I guess, acknowledging these challenges and disparities with receiving diagnosis is a part of that work. All right, we're going to get into specifically about autism. So autism spectrum disorder, as it's formally called in the DSM, is a neurodevelopmental condition that affects how a person experiences communication, social relationships, sensory information, play, learning, and patterns of behavioral interest. Autism is described as a spectrum because autistic people have a wide range of strengths, differences, support needs, personalities, and ways of interacting with the world. Current research suggests that an estimated 1 in 70 people in Australia are autistic. It's important to note here that Asperger's syndrome, is no longer recognized as a diagnosis. So in the most recent DSM, this was taken out as a diagnosis because language has moved towards grouping all autistic people, including people who were previously diagnosed with Asperger's, as a whole. And that's why they're using the spectrum, because they no longer focus on Asperger's being similar to autism, but having a distinct category. Instead, now we talk about autism as being a spectrum, and some people have different challenges in that diagnosis than each other. Diagnosis uses functional labels. So there's level 1, 2, and 3 autism. It's important to acknowledge that many autistic people don't like this element of the diagnosis process, these functional labels, as they feel it can oversimplify how challenging autism can be for them. And they also might use terms like high functioning and low functioning, which also many autistic people as advocates don't agree with those terms. But I wanted to acknowledge that you might hear them used, and that the functional labels of level 1, 2, and 3 are part of the diagnostic process currently. It's important to note that autism is not caused by parenting style or by any emotional experiences or trauma. It's a lifelong difference in brain development and processing. I want to really highlight here that many autistic children and people have unique strengths, such as creativity, deep interest. They can be really honest. They can have really strong attention to detail, a really strong memory, and really interesting and original ways of thinking. But autistic children may experience differences or challenges in areas such as social communication interaction, understanding social cues, sensory processing. So they might be more sensitive to noise, touch, movement, textures, for example. Flexibility with routines and transitions can be challenging. Emotional regulation can be challenging. Development of play skills and forming peer relationships can be hard. And they might experience repetitive movements, interests, or behaviors that help them feel regulated and safe. Every autistic child is different, and an autistic child's presentation can vary and change over time and in different settings. But that doesn't mean that they're not autistic. They'll be autistic wherever they go, just might look different in different settings. From a play therapy perspective, autistic children often communicate important thoughts, emotions, needs, and experiences through their play, movement, sensory exploration, creativity, and behavior. And so in play therapy, we're able to support autistic children who don't necessarily need to use words. They can use their play and the ways that they engage in play therapy to communicate with us, and we can then build a support network around them. Play therapy aims to build safety, connection, emotional understanding, self-expression, confidence, and supportive relationships while respecting each child's individual neurodevelopmental profile. People with autism may find it hard to understand what others are thinking or feeling. They might get anxious about social situations. They might find it challenging to form friendships or prefer to be on their own. They might become very excited and overshare about a specific interest. They can show less facial expressions related to emotional state. They might prefer to not make eye contact. They might need to be in a routine and find it challenging when this is changed or interrupted. They might find it difficult to adapt their behavior or presentation to different contexts. They can take things very literally. They can be real black and white thinkers. They might need to engage in self-regulating repetitive body movements or vocalizations. You might see me refer to these as stims later, a more common way of referring to them. They can either have a higher need for sensory input, or so be sensory seeking, or be very sensitive to sensory input, sensory avoidant, or have a combination of both. I want to acknowledge that autism has a high level of genetic heritability. So when one identical twin is autistic, there is about an 80% chance that the other twin is also autistic. Whereas we look at fraternal twins, non-identical twins, this is around 40%. One twin is autistic, the other twin is autistic. If one child in a family is autistic, there's around a 1 in 5 chance that any other child born in that family will be autistic. And this also extends to the parents of autistic children. There's again that very high level of genetic heritability. And so one of the most common times for women, for example, to be diagnosed, if they weren't diagnosed in childhood, is if their child has been recently diagnosed. So a lot of parents might be going through the diagnostic process with their child and be thinking, this actually sounds a lot like how I experience the world. Or maybe the pediatrician might ask or suggest, I wonder if you've ever thought of being assessed before. wonder if this sounds like something that might also be happening with you. ADHD and autism also have a high comorbidity with each other. And so sometimes when a child is diagnosed with one, there might be an indication to assess for the other. And so current scientific literature shows that around 40 to 50% of autistic people also have ADHD. It's important to note with this research that up until the most recent DSM came out, you actually couldn't be diagnosed with ADHD and autism. You could only have one or the other. It was thought to be an exclusionary diagnosis. And so I guess the research showing that 40 to 50% of autistic people also have ADHD, that might go up over time based on the accessibility of being able to receive both diagnoses now. So now we're going to talk about the DSM. And so this is going to feel very much more like that medical model way of talking about autism as being a disability or a disorder. So the American Psychiatric Association, the APA, use this handbook, the Diagnostic Statistic Manual of Mental Disorders, or the DSM, in both the United States and much of the world, including Australia. It's viewed as the authoritative guide to diagnosing mental disorders, and that also extends to things like autism, neurodevelopmental disorders. In 2013, the 5th edition of the DSM came out, and this states that autism diagnosis requires persistent deficits. So you can see that use of the word deficit, very medical model, in social communication and social interaction across multiple contexts. And it needs to be manifested as the following: deficits in social emotional reciprocity, in nonverbal communication behaviors used in social interaction, and in developing and maintaining and understanding relationships. So the criteria specifically says that A, the child or person must have persistent deficits in social communication and social interactions across multiple contexts as manifested by all of the following. So when you're looking for diagnosis, you have to have all of these things. There must be deficits in social emotional reciprocity, ranging, for example, from abnormal social approach or failure of normal back and forth conversation to reduced sharing of interests, emotions, or affect, to failure to initiate or respond to social interactions. So thinking about that challenge with that back and forth conversation, challenge with that abnormal social approach, not really reading what's the right social cues necessarily in a social conversation. And that reduced sharing of interest, emotion, or affect, which we talked about earlier, that challenge with showing on your face for some people how you're feeling, leaning in, all the things that other people are doing in social conversation. You also need to have deficits in nonverbal communication behaviors used for social interaction, ranging, for example, from poorly integrated verbal and nonverbal communication to abnormalities in eye contact and body language, or deficits in understanding and use of gestures, to a total lack of facial expressions and nonverbal communication. So again, it's talking about those nonverbal cues around eye contact, body language, gestures, facial expressions, deficits in developing and maintaining and understanding relationships, ranging from difficulties adjusting behavior to suit various social contexts, to difficulties in sharing imaginative play or in making friends, to an absence of interest in peers. Again, making those friendships, making those connections with peers, playing together, particularly imaginary plays mentioned in the diagnosis criteria, adjusting your behavior to different social contexts. So when you're at school or at kinder, maybe you're a bit different than at home. Whereas in this diagnostic criteria, it's talking about not knowing that you need to maybe act differently in different settings. The other element that is mentioned in the diagnostic criteria is these restrictive, repetitive patterns of behavior, interests, or activities as manifested by at least two of the following, currently or historically. So it's looking at a history of what's been going on for your child. So these can be stereotyped or repetitive motor movements, use of objects or speech. So this is the stimming that we talked about earlier. Lining up toys, flipping objects, echolalia, which is repeating sounds over and over, and using idiosyncratic phrases, just repeating things maybe from TV or things that you've heard YouTube, different places, just repeating them to yourself. Insistence on sameness, inflexible adherence to routines or ritualized patterns of verbal or nonverbal behavior. So, for example, this can look like extreme distress at small changes, difficulties with transitions, rigid thinking patterns, different rituals, need to take the same route or eat the same food every day. So that sameness, that need to adhere to a routine or pattern. Highly restricted, fixated interests that are abnormal in intensity or focus. So, for example, a strong attachment to or preoccupation with objects excessively um, circumscribed, so that real focused in on one specific interest that are very intense. In this language, it says abnormally intense. Hyper or hyporeactivity to sensory input or unusual interest in sensory aspects of the environment. So this can look like indifference to pain or temperature, adverse response to sounds or textures, excessive smelling or touching of objects, visual fascination with lights or movement. So again, that we talked about that earlier, that's sensory differences. People can be really drawn to, hyper reactive, really avoidant of sensory, or hypo, like a bit like low input. So they need lots more sensory input to sort of receive that message in their nervous system. It talks about that symptoms must be present in early developmental period, but might not fully manifest until social demands exceed capacity, or can be masked by learning different strategies later in life. So we talk about masking, that sort of performing or suppressing your autistic needs to present in a neurotypical and a typical manner in different settings. Autistic people often learn to do that over time, but it's not ideal to mask. It's not great. It causes a big stress and input onto the nervous system on that person. The symptoms need to cause clinically significant impairment in social, occupational, and in this context that can mean school or kinder or the workplace if we're looking at adults, or other important areas of functioning. And these disturbances can't be better explained by other diagnoses like an intellectual disability or global developmental delay. And the last part of the diagnostic criteria that I mentioned earlier is this level way of looking at it. So the current severity is based on these different things I've listed, that social communication impairment and restricted repetitive patterns of behavior. The person can either be diagnosed with level 3, requiring very substantial support, level 2 requiring substantial support, or level 1 requiring support. So when you have your child assessed, they'll talk about these different levels as part of the criteria. So you can see, I guess, the two different ways I've spoken about autism sort of sit in those two different models of disability. This is what the current diagnostic criteria look like, that really medical model. Whereas my previous slide, I tried to be much more of that social model of looking at there are differences in this person's way of being in the world, but we can also support them with those differences. There's no need to talk about it being so intensely negative, I guess. You might have seen lots of people, and we already briefly touched on this concept of a spectrum and being on the autism spectrum. So the concept of a spectrum in regards to autism aligns with the idea that each person is different and their diagnosis will be unique to them rather than just falling into set categories. So often people coming into the clinic whose child's been assessed, they might say, oh, they have level 2 autism. We think about this spectrum, we can think about that even if someone is diagnosed with level 2 autism, for example, what that looks like for them will be different than another child who's diagnosed with level 2 autism. Because there are lots of different ways and different elements that can be impacted and that need support. So this model can align itself more closely with that social model of disability as it sees each person as unique with different strengths and challenges that need support. Within this concept of a spectrum, there are a few additional elements that I wanted to mention. So the first concept you might have heard of before is having a spiky profile. So when someone has a spiky profile, it means there's a big difference in their level of ability from one area to another. So this person might be really great at doing one thing, but then really struggle with something else. Maybe they're really good at the interpersonal skills, but they really struggle to stay on top of paperwork. Or they could be an amazing story writer and have a really amazing imagination, but they might find it really hard to stay on top of their cleaning and day-to-day tasks. And so people in children with spiky profiles often find that people either over or underestimate them based on their capacity in other areas. So if you only saw someone with a spiky profile, for example, at school, and they're incredibly focused on their schoolwork, you might assume that they don't have support needs in other areas because you've only looked at one area of their profile. But this child might be going out in the schoolyard and being completely overwhelmed by engaging in social interactions, for example. The other element that's important to mention about it under this concept of a spectrum is this idea of fluctuating capacity. And so the capacity for tasks and engaging in different areas for autistic people can change day to day or over time. And this is generally based on their overall functioning and how they're going, how much masking they might be doing, how regulated they're feeling and how much co-regulation they're accessing and how many supports are in place. So it's really common to hear parents in my line of work talk about how, again, schools or kindergartens say that a child is doing really well and they're not seeing the challenges that the person is seeing at home, the parents are seeing at home. And often what I'm curious about is this because the child is really well supported at school? And that's what we want to see in our school or education settings. Or is it the child is engaging in things like masking, holding on to all their regulation needs and suppressing those? And then when they get home, they've got to let that all out. So that fluctuating capacity even can look at over the day. That your child might be really holding it together and really doing their best at school as they know that's what's expected of them. And then a big crash might happen when they get home. So it's important to, when you're working in a team of people, to talk about that fluctuating capacity. How challenging is it over the day or over the week for your child? We're going to talk about being neurodiverse affirming. So in regards to being neurodiverse affirming in our parenting practices, we must begin with acknowledging and fostering the belief in ourselves that autism is not inherently something wrong with a person. So adopting that social model of thinking about disability, and instead think about autism as just a different way of being. Autistic children don't need to be fixed, although they may require support at times, just like any child might. And that's an important element, is that regardless of whether your child is autistic or not, our children all require support at times in different ways. And so it's just a different way of thinking about, yes, my autistic child needs more support at times than others, but all children need support. And so acknowledging that autistic children are wonderful just as they are. There's nothing wrong with being autistic. Within this, we can acknowledge the challenge that comes along with parenting a child whose brain is wired differently, and that many in our world may view as naughty or defiant, or that autism is something to be changed or suppressed. That's really challenging to support your child, knowing that the world sort of views autistic people and people with lots of different neurodivergent identities as something that needs to be fixed or changed. Parents of neurodivergent children often need to become advocates in different situations, whether this be in kindergarten or school, amongst family and friends, or in the broader community. This can look like educating those around our child and advocating for therapies and strategies that align with the core belief that autistic children don't need to be fixed. Parenting a child who has different challenges to those of their neurotypical peers can feel very isolating at times. And so engaging in connections with other parents and learning from neurodivergent community members can be one of the most important aspects parents can do as part of their journey, so they don't feel as alone. I'm also going to talk specifically about neurodiverse affirming practitioners. So when looking at support options such as therapies or allied health services, or when looking at education settings like schools or kindergarten, you might come across places promoting themselves as neurodiverse affirming. There are a few key concepts to have in your mind whilst assessing if somewhere is really actually neurodiverse affirming or whether they're just using that term. It's become a bit of a buzzword or a key term that lots of people are using. So it's important to know, are they actually neurodiverse affirming? The following elements are considered non-negotiable, and so they must be doing these to be considered neurodiverse affirming. And this list comes from the work of Sunny Jane Wise. Their handle is Lived Experience Educator, and they're a really helpful resource in terms of this neurodiverse affirming paradigm. So the goals should be defined by the individual only. Obviously, with very young children, this can be challenging, and this might be a conversation that's also had with parents. But the goals need to come from what the person themselves feels like they would want to work on, rather than that idea of telling someone how they need to be or what they need to change. The person should listen to and learn from lived experience of the community that they're supporting, which is why at the beginning I acknowledged that I sought out information and references from autistic people as part of this presentation. They should reject neuronormative definitions of success or independence. So again, moving away from that idea that there's one right way to be and what that would look like in terms of success or independence. The practitioner's focus should be on reducing distress of the person rather than traits. So instead of saying, oh, we shouldn't stim, that's a very autistic trait. Instead, we should be like, well, what's making you distressed that's causing this heightening of your nervous system, which might lead to stimming. They should allow individuals to define what's meaningful for them, as well as what's functional or distressing for them. So again, if I use that example of stimming, for some people, stimming is a really functional way that they learn to cope and to regulate. And so we don't want to remove that if it's not actually distressing for them, for example. They should recognize, accommodate, and respect stimming, sensory needs, eating differences, special interests, and communication needs. The person should prioritize connection over compliance. So we never want to teach people or children that they have to be compliant to be worthwhile or to be in a relationship or have connection with someone. They should value different ways of playing, socializing, paying attention, and learning. They should presume competence. So often people who are not neurodiverse affirming might assume that if, for example, there's no verbal communication happening, that person isn't understanding or is not competent about what's happening, which is not necessarily the case. We should always presume that people are understanding and able to engage with what we're doing. They should focus on the why behind all responses, behaviors, and distress that's going on for that person. So looking underneath their behavior and being curious about why that's happening. We should teach and encourage self-advocacy in our autistic children and in all people with a disability. Accommodation should be given and available regardless of that diagnosis. We talked about that earlier in this presentation. We should recognize intersectionality and the different ways that our identity and our experiences and our culture, gender, all those things interact with each other, which is also I talked about a little bit earlier in regards to that receiving diagnosis. And we should respect everyone's autonomy, whether that be through mind or body. All these things should be happening in neurodiverse affirming practitioners or education spaces. Some signs that a practitioner is not neurodiverse affirming are that they prioritize compliance or label individuals as non-compliant. And that can look like in education settings or in allied health. They might withhold a desired object or activity to achieve compliance. So you can't have this until you do this thing. They might do things like enforce eye contact or that you have to keep still. They might use exposure and tolerance to treat sensory and eating differences, so making people experience discomfort and distress through exposing them to non-preferred sensory or food experiences. The focus can be on getting the person to fit in and appear normal or meet neuronormative goals, expectations, or standards. So again, not really allowing someone to be okay as they are, talking about that, well, everyone else does this, so you need to do this. They can prioritize compliance. I've already done that one, sorry. They can reinforce binary ways of thinking. So there's something's either right or wrong or normal or abnormal, rather than allowing people to just themselves define what's meaningful for them. And they might refer to individuals as naughty or lazy or attention-seeking or demanding or needy, using all those sort of negative labels to talk about someone rather than looking underneath their behavior. So it's really important to think about when you're in different settings, and we talked about just before how often you need to be an advocate for your autistic child. When are these sort of non-neurodiverse affirming things coming in? Lots of these things can be damaging to your child's development and self-esteem. And really put in some of that challenge around, developing that positive self identity around being an autistic person, and that it's okay and fine to be autistic. So how can we support our child? I've organized some support ideas into these 4 categories: sensory, social, emotional, and executive function. It's important to acknowledge that every person is unique, as I've talked about lots here, that spectrum. And so not all strategies or concepts in this presentation are going to apply to everyone. And so if you have an autistic child in your life, any support ideas should be planned alongside that person where possible. If they're able to sort of give input into what feels good and helps them feel supported, it's really important to ask them. I'm going to talk about sensory first. So understanding sensory needs. If we talk about sensory, these sensory differences can affect things like sound, touch, movement, smells, taste, and light. And some signs that a child might be experiencing sensory overwhelm could be covering their ears, avoiding certain clothing, feeling increased irritability, having a meltdown. We're going to talk about meltdowns in a couple of slides. Seeking movement, wiggling around. So in terms of supports that we can put in place, if we're thinking about sight, we might think about different types of lighting and avoiding lots of visual clutter, having lots of things in the environment. If we're thinking about touch, we might be advocating for access to sensory items like fidget toys or weighted blankets or alternative seating, so bean bags, wiggly chairs, sit-stand desks. We might be thinking about the kinds of clothing that we dress our autistic child in. So we want them to be comfortable. We don't want them to be too tight or too hot, although some people do enjoy really tight experiences like those sensory stretchy socks you can get. In terms of smell, we might want to avoid wearing or using strong or overwhelming scents, especially in communal or close spaces. In terms of temperature, we want to think about how we can build an environment that's not always at an extreme, so either heater on all day or aircon on all day. We don't want to have those really extreme temperatures for people who are more sensitive to temperature. We might use items like blankets or fans or warm clothing to support the temperature feeling comfortable for that person. And we also want to support that checking in or development of interoception. So interoception is the sense of knowing how your body feels in time and space. And so often people who are autistic can find interoception challenging. So supporting to check in, oh, I can notice you're a bit warm and sweaty or your cheeks are a bit flushed. I wonder if you're too hot. I wonder if you need the toilet. You're wiggling around a little bit. Are you feeling hungry? Are you thirsty? All those sort of things that help us learn to attune to our body's communication about its needs. And sound is another important one. So allowing things like noise cancelling headphones or having that music on for sensory input. In terms of different environments, we might want to have quiet spaces, both at home and in school or kindergarten. And these should be away from noisy areas. And so children are able to go and withdraw and engage in those if they need to. We've talked about stimming a little bit already, but stimming is a normal way for neurodivergent people to regulate their bodies. Everybody has regulation needs, whether they're neurodivergent or not. But stimming is often how neurodivergent people regulate their bodies. People stim for lots of reasons. This might be to express big feelings like joy, anger, overwhelm, sadness, anxiety. It can be used to self-soothe, to motivate, and to up or down regulate their nervous system. It's important to allow people to stim in ways they feel positive about, not thinking, oh, well, I'll just give you a fidget spinner and that'll meet that need, when this person might have a very different way of stimming, usually. It's important also to acknowledge that focus and attention do not look the same for each person. So someone might be working really hard to sit still and look at their teacher, for example, and make eye contact, but that might be taking up all of their capacity. And so actually the information that the person is saying is not really going in. Whereas if that person was able to look down, not make eye contact, wiggle around as they need, maybe flap their hands, whatever they need to do, their body is regulating through that. And so they are actually able to take in that information. And so when we're talking about that neurodiverse affirming practice, we want to know, what does focus and attention actually look like for my child or for me? And supporting that to be appropriate and acceptable in all different environments, including school or kindergarten. We're going to talk about social support. So I want to start off by talking about the double empathy problem. This is a concept that was developed by Damien Milton in 2012. And it suggests that communication difficulties between autistic and non-autistic people are not solely the result of autistic people having social deficits, which is what the DSM would suggest. Instead, difficulties arise because autistic and non-autistic people experience and interpret and communicate about the world differently. So the traditional view historically is that autism was understood as involving deficits in social communication, with the assumption that autistic people struggle to understand non-autistic people. But the double empathy problem proposes that autistic people may find non-autistic communication styles confusing, and non-autistic people may also find autistic communication styles confusing. And so there's that misunderstanding happening on both directions. There's no one person that can be sort of thought of to blame, I guess. Both parties may struggle to accurately interpret each other's interactions, emotions, and perspectives. And so, in other words, communication challenges are often a mismatch between two different ways of experiencing and communicating, rather than a problem that exists only with the autistic persons. This is a much more social model way of looking at these communication challenges, or social deficits, as the DSM would say. So an example of how this looks in the real world is that a parent might ask their autistic child, "Are you excited about your birthday party?" And the child might respond, "The cake is chocolate." So the parent might then think they're ignoring my question. But the child themselves might be thinking, "I'm communicating excitement by talking about the part of the birthday party they're the most looking forward to." So this misunderstanding occurs because the child is communicating in a way that feels meaningful to them, and the parent expects a different style of communication. They're expecting the child to say, "Yes, I'm excited about my birthday party." Neither person is really wrong in this situation. They're just approaching the conversation from different perspectives. And so what research has found is that autistic people often communicate effectively with other autistic people, and non-autistic people often communicate effectively with non-autistic people. And so misunderstandings are more likely to occur when people with different communication styles interact with each other and aren't aware that another communication style is being used. So this suggests that social difficulties are often relational and context dependent, rather than being located entirely within the autistic individual. So in terms of implications and support strategies for parents or people who have autistic children in their lives, the suggestions are that we be curious about the meaning. Instead of focusing only on how a child communicates, you might consider, what are they trying to tell me? And how does this communication make sense from their perspective? You might be thinking about adapting communication both ways. So communication is most successful when both people make adjustments. So this is that difference between assuming or asking an autistic person to communicate non-autistically. Instead, we want to both be working to find a shared understanding with each other. So examples of adjustments you can make as a non-autistic person is using more visual supports, giving additional processing time, reducing reliance on like implied or secret meaning, like being very explicit and concrete in what you're saying. It makes it less likely there's been a misunderstanding or misreading of what you want. We want to value different communication styles. So communication can include lots of different things, including gestures, AAC devices, text cards, echolalia, like that repeating of things, special interests, body language, and behavior. All of these communication elements can carry important meaning. We want to focus on connection over normal or typical communication. So the goal is not to make autistic children communicate like non-autistic children. The goal is to develop mutual understanding, trust, and connection. The double empathy problem reminds us that communication difficulties are often shared. Rather than asking autistic children to do all the adapting, we can work together to understand each other's perspectives and build communication bridges. It's a really helpful way of thinking about social challenges for autistic people or children. The other element I really wanted to talk about in terms of social is around special interests. So I've got my two special interests up here on the screen. Pokemon has certainly been my special interest since I was a child. And a more recent special interest of mine is Minecraft, which is a bit of a common special interest for autistic people. So special interests are intense, focused passions or areas of interest that many autistic people develop. These interests often bring significant enjoyment, comfort, learning opportunities, and a sense of identity. Special interests can involve almost any topic, and some examples might be animals, trains and transport, dinosaurs, space, art, technology, maps, nature, music, books, specific TV shows or characters. Some special interests might last for many years and others can change over time. Special interests are often more than hobbies. They can provide joy and motivation, help learning and skill development, help reduce stress and anxiety, offer a sense of predictability and control. They can build self-esteem and confidence, and they can create opportunities for connection with others. For many autistic children and people, engaging in a special interest can be regulating, calming, and this can be particularly noticeable during times of stress or uncertainty. I know for me, engaging in my special interest is incredibly important to me and really brings like joy and regulation into my life. I can't really go on about how enjoyable it is for me to talk about these two topics and some of my other special interests. So in terms of how special interests actually support development, they can support communication because children are often most motivated to communicate about topics they love. They can support learning. So these special interests could be incorporated into reading or writing or maths or problem solving, social learning. For example, a child who loves dinosaurs may be more engaged in reading books, writing stories, or practicing counting using dinosaur-themed materials. It can be really helpful in schools and kinders. They can support development in relationships. So special interests can help build connections with parents, siblings, teachers, therapists. And so showing a genuine curiosity about a child's interests can strengthen trust and connection. And your child might find other children with a shared special interest, and that can be a really great way of supporting friendship development. For example, we've got a Minecraft group at our setting, and for some of these children, Minecraft is absolutely their special interest, and so they're able to engage in playing Minecraft together and talking about Minecraft, which all of them enjoy doing. They all enjoy talking about Minecraft together. Some common misunderstandings around special interests are that talking about the same thing all the time is unhealthy, but in reality, special interests are often a meaningful way that autistic children learn about the world, express themselves, regulate their emotions, and connect with others. Whilst we might think that balance is important, special interests should not automatically be viewed as a problem. It's really important to know that special interests are important and can be very positive for people. In terms of how parents might support special interest, we would encourage you to follow your child's lead. Show interest in what your child enjoys, ask questions, learn alongside them, listen to what excites them. You might use their special interests as a bridge, so you might incorporate these interests into daily routines, learning activities, communication opportunities, and social interactions. It's important to respect their passion, so avoid dismissing interests as obsessions or fixations. Instead, recognize them as an important part of your child's strength and identity. And gradually encourage flexibility where possible. So children can learn over time to balance their interests with other activities while still feeling their passions are valued and respected. Special interests are often a source of strength, joy, comfort, and learning for autistic children. And so rather than wanting to eliminate them, parents can utilize these interests as powerful tools for connection, development, and emotional well-being. We're going to talk about supporting play. So play, couldn't talk about it enough as a play therapist, is really important for all children. Play is how children learn, explore relationships, express emotions, and build confidence. And so the ways that parents can support this play development and engagement in play for their autistic child is to follow your child's lead, to join their interest, to, comment more than question, to sort of do that tracking, that naming what you're seeing, rather than saying, are you doing this? What's this? Etc. Focus on connection over teaching within the play. So we don't want to always be doing that educational play. What color is it? How many are there, for example? Just focus on being with your child and enjoying the play and allowing repetition and preferred play themes and styles. So allowing your child to do the same thing over and over to either, as that often provides them with regulation, or they might be working through something, so they might need to engage in the same thing over and over. They might really enjoy playing a specific type of play or theme, and that's okay. Remembering that connection is more important than correction. So again, that engaging with someone, building a bond with them is often much more important than correcting what they're doing. And that all kinds of play are valid. So again, if your child just enjoys playing with trucks, lining things up, sorting, whatever kind of play that they like, sensory play, that's okay. I know in the DSM criteria, it talks about that challenge with imaginary play. And as in our play therapy context, we do learn to play therapy, which does support children, including autistic children, to practice imaginary play. But if your child is not into imaginary play, that's okay. There are lots of different kinds of play that they can engage in and that you can engage in together. Here's some support strategies around emotional regulation. So the first what we're going to talk about is that co-regulation before self-regulation. So children learn to regulate their emotions through supportive relationships and repeated examples of having co-regulation, being regulated with somebody else. The strategies around this are to stay calm and predictable, to validate your child's feelings, to use a calm voice, to offer comfort if the child wants that, to reduce demands when they're feeling overwhelmed, and to model coping strategies. I'm going to take a deep breath. I'm going to wiggle around and move my body and get all that energy out. So examples of how this might look are deep pressure, if your child enjoys it, including that weighted pressure, having quiet spaces, having sensory tools, having movement breaks, all those sort of things to support that co-regulation. It's important to note that for autistic people, emotional extremes, that might go from 0 to 100, can be common. People might experience that flat affect, that sort of not a lot of visual emotions happening on their face. There might be a delayed processing of emotions, so it can take some time to process before having that emotional reaction. Might be like a day or two later, you might be like, oh, actually, I really didn't like that thing that happened. There might be really intense emotions or hyper empathy. Some autistic people talk about being hyper empathetic, really, really feeling their feelings, particularly about others. And there can be heightened empathy and emotions towards animals or inanimate objects, that really identifying emotionally with different things. Outward expressions of emotions can change quickly when there are changes in the environment, routine, or experience. We talked about that earlier. Some children, autistic children, really need predictable routine, and that when that's not happening, there can be that really heightened outward emotional experience. There can be challenges with that outward expression of emotional facial expression that might not match internally how someone's feeling, or might not look the same as other people. So you might learn that actually when your child does this or this behavior happens, that actually means that they're feeling upset or distressed, even if that's not how you yourself might look when you're upset or distressed. We're going to talk about autistic meltdowns quickly. So autistic people often experience autistic meltdowns. And this is a natural nervous system response to feeling overwhelmed and having emotional or sensory flooding happening in the body. The body enters that fight, flight, freeze response, which is a response that all of our bodies are capable of doing, whether we're autistic or not, which you can think of as similar to responses seen in like someone who's got PTSD, for example, or anyone who's experiencing any kind of heightened sense of stress. This can look like externalizing, so throwing, yelling, crying, absconding or running away, maybe self-injury behavior, banging your head on the wall, or it can be internalized. So shutting down, hiding, being nonverbal, unable to speak, curling up in a ball, or feeling really distressed, or having those really, really challenging, like suicidal ideation thoughts, wishing that you weren't here anymore. It's important to note that it's not a conscious choice that someone's making, and it's not a behavior that requires punishment. They're not choosing to do it, but it's an indicator that someone needs support and understanding both in that moment to regulate and de-escalate, and then also after the meltdown has finished to work out how to prevent that from occurring in the future. So during an emotional escalation, it's important to stay calm, to reduce language as much as possible, to ensure that that person is safe, to offer support, and to allow recovery time after the emotional escalation. We want to avoid lengthy explanations, arguing, punishment when they're distressed, and demanding things like eye contact during that moment. And after the emotional escalation has regulated and calmed down, that's when we might talk about what happened and how we might prevent that in the future, or what might have led up to that moment. I wanted to mention the window of tolerance really quickly in neurodiversity. So research has shown that autistic children have a smaller window of tolerance. You might be familiar with this concept and you might not, that's okay. Which means they might become over or understimulated more easily. So a window of tolerance is our part when we're feeling regulated and safe and we're able to engage. We might still feel emotions. We might feel happy, sad, all the normal emotions that we all sort of feel, angry, but we're not emotionally flooded or dysregulated so much that we can't engage our thinking brain and we're not shut down. And so autistic children can have a smaller amount of time where they remain in that regulated, engaged state, and they might sort of fluctuate between these two fight, flight, outward expression of dysregulation and this freeze state of dysregulation. Let's talk about executive function. So the executive function part of your brain is the control center that it controls things like impulsivity, forward planning, impulse control. Oh, did that one already. All the kind of things that we need to sort of get functioning each day. And so it can be important, as we mentioned earlier, with this executive functioning to have predictability. So many autistic children thrive with things like routine, consistency, and preparation or warning if there's going to be changes. So some helpful tools around this are things like visual schedules, timers, or countdown warnings. So knowing I've got 5 minutes left of this. Social stories that help children sort of make sense of what's going to happen and prepare for new experiences or changes. You can use things like first and then boards. So an example can be first we'll have dinner, then we'll play on our iPad. It's important to note that things like executive functioning tasks are often the parts socially or in a society that we value as like good or positive. If you're really good at impulse control, you're really good at planning, you're very organized, you're very in a routine. And this can really impact the self-esteem of people who don't find these things easy or who have executive dysfunction. So it's important instead to remove any kind of morality or judgment to executive function tasks and just acknowledge them as elements that some people might need support with, and that's okay. We can support those things. Some more support strategies that can be helpful include breaking focus time into short sections, so chunking different activities into little sections or tasks, sticking to a routine that avoids changes where possible, giving 5-minute warnings before transitions, having increased reminder frequencies if your child finds it hard to remember what to do or gets overwhelmed or distracted easily. You want to give short, clear instructions, breaking that task down into 1 to 2 steps at a time. It might be helpful to give assistance with what is important to do first. Sorry. You might want to use the person's strengths or special interests, as we talked about earlier. So making a visual routine that uses Bluey, for example, if that's an interest of theirs. And remembering those fluctuations in capacity and planning around those known times if possible. So if you know your child's got lots on, you might not choose to then do something really mentally challenging that same week. More strategies and ideas just quickly are around advocating against strategies that promote the idea there's only one right way to do something. For example, full body listening talks about that idea of sitting still, looking at the person who's speaking. We want to advocate against that because we know that people can pay attention in a number of different ways with their body and their eyes looking wherever they need to. We want to create environments that are low demand both at home and in educational settings and have as much possible extended periods of play or free time, have less transitions where possible, and have opportunities for choice rather than whole group experiences. So again, if you find being in a social environment challenging and you're overwhelmed by lots of sensory or noise, you might not really enjoy being in a whole group. So having as much possible opportunities for individual work or small group work can be really helpful. We want to support children to play and engage in ways that they like instead of what might be expected from neurotypical children. We talked about that earlier. Learning about children's interests and showing interest in these and creating dopamine opportunities. So wherever possible, allowing those special interests to be utilised. And as we talked about earlier, that development of interoception through modelling, use of self, so saying, oh, I'm really hot, I'm going to take my jumper off, I've been running around, my heart's going so fast, I'm going to take a drink of water. Naming those emotions and body-based experiences can support that use of interoception. I wonder how you're feeling. I'm feeling this. I wanted to briefly talk about having a sibling who is autistic or being a parent of an autistic child again. So siblings with autistic children in the family, so non-autistic siblings, can feel protective or frustrated by having a child in their family who experiences the world differently. They might need individual attention themselves and they might have questions about autism. So some helpful approaches can be having that open communication. There's nothing wrong with being autistic. And so it's okay to talk about how your brother has something called autism, and that means that these things are a bit more tricky. Giving your non-autistic child as much one-on-one time with you as possible can be really important. Having that education around autism and having opportunities to share feelings openly. It's okay to be frustrated, or it's okay to feel whatever you feel about having an autistic sibling, and we open and acknowledge and accept all those feelings that our siblings are having. In terms of parenting can be really tricky and it can also be really rewarding in general, but certainly with a child in your family who's autistic, parents benefit from having support networks, having time for rest, having self-compassion and care. and accessing practical help when available. So it's important to remember that supporting yourself and filling up your cup helps you continue to support your child. It's not selfish to need time for yourself. It certainly helps you continue to give to your children if you're able to do that. The most important takeaway I hope people take from this presentation is this concept that kids do well when they can, which comes from Dr. Ross Green's work. So the foundation of this approach is realizing that all kids do well if and when they can do well. Everybody wants to be liked, everybody wants to fit in and to be positively received in your environment. And so if your child is not doing well, if they're having challenges in environments, we want to avoid doing that sort of non-neurodiverse affirming way of looking at what's happening as, labeling them as defiant or attention seeking or manipulative or any of the other frequent judgments that people might use about children. Instead, we want to think, okay, they're not doing well, so they need my help and support. We want to look beyond the behavior and think about what's happening underneath the surface. Why are they finding this challenging? And this is also what we'll be advocating for in any setting that children are in, including education settings and therapeutic settings. Here are some helpful resources that I would suggest. I feel like I'm covering one of them, but it's just reframing autism down the bottom there. Some of these ones are ones that I accessed to put together this presentation, and others are just suggestions of helpful support resources. If you have any questions or you'd like to discuss referrals, if these are people watching who don't have their child engaged with us currently, these are my contact details and our general practice contact details. We've got a clinic in Baldwin North and we also offer outreach, particularly around like the Melbourne East area. But we also can do outreach from our Baldwin North location as well. You can get in touch with us either via these email addresses or the phone, or you can access more information on our website. I want to thank everyone for tuning in and spending some time with me talking about supporting your autistic child. Hopefully this information has been helpful, and I look forward to hearing from some of you in the future.